So that is, if you, now you imagine that if it is descent, so there is pressure on the ureter or not? Pressure in the ureter. If there is a pressure in the ureter, so ureter always try to control her anatomical position by hypertrophy and hyperplasia, mostly hypertrophy. So there is, and there is also stasis of the ureter. So there is hydroureter. So another complication is the hydroureter. Why? It is always that is ureter try to control her position. And bladder, there is also bladder, there is some change, increased rugosity and stasis of the urine. All these condition causes urinary tract infection. Okay? All these changes causes urinary tract infection. So there is hydroureter, cystitis, stasis of the urine, and as a whole, lastly, it is causes. There is obstruction, it may cause also ureteric obstruction. Ultimately, it causes urinary obstruction. Okay, if ureteric obstruction, that may be associated with renal failure. Even renal failure also one of the complication due to uterine prolapse. So now you imagine what are the complication of the uterovaginal prolapse, the pelvic organ prolapse. How incidence so high? Incidence is so high in case of multiparous women. Another case, you know, that is surgical injury can cause prolapse. Yes, sometimes you know that abdominal hysterectomy, following abdominal hysterectomy, if not correctly or properly not done, or the other associated factors not corrected, then also causes, you know, the vault prolapse. Vault prolapse is the vaginal wall prolapse. If you remove the uterus from up, what are the remaining structure? Vaginal wall. You know the vaginal wall, na? Vaginal wall. So vaginal wall also become prolapse. That is called vault prolapse. It one of the complication after abdominal hysterectomy, even after also vaginal hysterectomy. Yesterday I did vaginal hysterectomy. Who saw? I think 4th year. They saw the vaginal hysterectomy. Anyway, I bring the that is a video of my operation. Luckily, we saw some portion at the beginning. There no electricity, so I cannot open. Anyway, I can give you later. Okay, now what you know? So, if uterine prolapse, what may be the sign symptom? You should always imagine the anatomy and physiology and pathological changes. So you can easily say the complication and sign symptoms. Now you say if the if the prolapse, okay, if the prolapse, then what would be the first complication? Most of the time, urinary problem. What are the urinary complaint? Increased frequency of micturition, stress incontinence, you know, the when patient walking, laughing, position change, then urine, dribbling of the urine. That is called stress incontinence. That is called. So, what are the one complication? Increased frequency of micturition and incontinence, urinary incontinence. Mostly stress incontinence due to erythrocele and cystocele. Okay? And you know the another complication, if vagina is full of uterus, the cervix, then what she feel? Always fullness of the vagina, always something in the vagina, always some discomfort in the vagina. So fullness of the vagina, discomfort in the vagina by the cervix and the uterus. Okay? And then another is you think that rectocele. What is rectocele? Rectal wall through the posterior vaginal. Rectal wall protrusion through the posterior vaginal wall. So what would be the complication? Possible complication what would be? Patient always there is backache. The most of the time prolapse patient complain backache and constipation, difficult to urinate and defecation, difficulties in defecation, constipation, backache. These are the other symptoms of the patient. So urinary symptoms and defecation problem symptoms are associated with the uterine prolapse. Okay, and if there is ulcer, there is more discharge, most of the time that is blood stain discharge. Also, the patient come to us with bleeding, pervaginal bleeding due to ulcer. Okay, this is the symptoms. Now, what are the examination and what are the differential diagnosis? Now, you see the differential diagnosis. That means what can confuse with the uterine prolapse. If you think the vulval tumor, suppose polypoidal growth from the vulva, it may be confused as the uterine prolapse. Okay, and elongated hypertrophied cervix, that is also confused with the uterine prolapse. Uterine inversion, you know the term, the uterine inversion. Sometimes uterus inverted. So myomatous polis, Gardner cyst, these are the differential diagnosis in the uterine prolapse. So how can you differentiate from one to each other? Always we know from history, from examination and from sometimes investigation. Okay? So vulval tumor and uterine prolapse. If you examine, it will be look same. Usually prolapse, if cervix, uterus is prolapse. Cervix has two key lip, anterior lip and posterior lip. Cervix has two lip. If vulval growth, is any lip in the vulval growth? No, there is no lip like cervix. So inspection, there is no lip in the vulval growth. But in uterine prolapse, there is anterior lip and posterior lip. Okay? And if you cough, like sometimes cough test, if you give pressure, cough like this, there is increased rise of the intra-abdominal pressure. If intra-abdominal pressure rise, prolapse is more, but vulval growth in the same position. So appearance and like this cough test, we can differentiate. And there is another is the Gardner cyst. You can show this. You can imagine that it is normal position, and rectum you see there. This is how it is come down. It is retroverted uterus. Posteriorly, sometimes anteverted and retroverted. Sometimes anatomically, sometimes it is about 15% case retroverted uterus. And if retroverted uterus is any complication, is sometimes more backache, sometimes backache due to the retroverted uterus. And if pregnant, there is chronic urinary retention of the that is due to retroverted uterus. Okay. You see what enterocele means? Intestine comes down through the pouch of Douglas. That is enterocele. Understand? The intestine comes down through the pouch of Douglas. That is enterocele. So what is you can show the cystocele. So how can we do pelvic examination? Intra-abdominal pressure I told already by giving cough. So one of these, that how can we prevent? Vaginal delivery, birth injury is one of the important cause of the prolapse. So we should during labor, we should manage the second stage of labor very carefully, without no necessity of the undue pressure, just bearing down pressure at the right time, and episiotomy if needed give correctly, and if there is perineal tear it should be repaired properly. And after that is important, is casual exercise. All of you should know, there is women's exercise. That is every woman, even after 30-35 years, should do the casual exercise. Casual exercise to strengthen the perineum. and vaginal wall. How it is done? How it is done? It is by holding the breath, and you should feel like this. You can hold the urinary and that is stool holding, that is defecation. You can hold the defecation reflex and the urinary reflex by holding this, so that it gains the strength. Not during urination or defecation, but you should imagine, you should think by sitting like this, by sitting position like this, just you hold 1, 2, 3, 4, 5, 6, 7, 9, 10 and then relax. Okay? And every day at least they told 50 times. 50 times. So if we pray 5 times, every prayer, after every prayer we can do 10 times. So casual exercise is important to regain the strength of the perineum. And it is so important for every woman. And estrogen replacement, sometimes I told you that is postmenopausal women suffering. So as there is estrogen deficiency, we can give her estrogen replacement by orally or by giving vaginal pessary sometimes containing estrogen. Okay? Another is cone. That is, these are some devices we place in the vagina, and it can regain the strength of the supporting ligaments. And I show you that this is other exercise devices. Something putting in the vagina, it is better to do this. This is important, the pessary. This is different types of the pessary. In our country only this is available mostly, but it is the others are siliconized. All are siliconized. Others are costly, but it is also used for ectosil like this. And sometimes it is used. This is for cystocele correction. Sometimes both anterior posterior all prolapse vaginal wall, then mostly it is used. Sometimes also according to that pelvic organ prolapse are different types of the prolapse. Different types. So we need to examine properly, we need to classify properly, and then we select which pessary is needed. Sometimes now UK, I have training on the UK in Croydon University for 1 month. They most of the times they no need of the operation. Only they select these devices and put them, and they take the biofeedback from the patient. And they different size also. There is different sizes. Okay. So this is also one of the treatment management. So another is prolapse surgical management. So if vaginal uterine prolapse total, that is patient cannot tolerate anything, then we select the vaginal hysterectomy. But along with this, what we do? If there is cystocele, we correct the cystocele by the anterior colporrhaphy. That is called anterior colporrhaphy. Okay, that is called anterior colporrhaphy and posterior colpoperineorrhaphy. If there is anterior cystocele correction, there is anterior colporrhaphy. And if you do the posterior correction, that is called posterior colporrhaphy. You see here, I will show in the living body, but you should imagine here, vaginal wall separated from the bladder and then repair. And there is another operation without removing the uterus, that is without doing vaginal hysterectomy, that is called Fothergill's operation. That is another is Fothergill's operation. That is we keep the uterus, only we do the amputation of the cervix and we shorten and tighten the all tightening ligament. That is called Fothergill's operation. There is 5 components in the Fothergill's operation. You should have dilatation of the cervix and separation of the vaginal wall and clamping and cutting, shortening of the ligaments and amputation of the cervix and repair of the cervix. That is called Fothergill's operation. another operation without removing the uterus. This one, 2, na? This is my operation I have done while I am in Kishoreganj. It's medical. What is the position? Lithotomy position, and anesthesia given is spinal anesthesia. And usually I do, as you know, the vaginal wall so vascular, so I use diluted adrenaline. It is one ampoule in 200 normal saline I put. Why? For vasoconstriction. For vasoconstriction I use diluted adrenaline. And I am giving this through all the surface of the vagina, and then it is given posteriorly also. And what is this instrument? Ellis tissue forceps. This is lateral vaginal wall, and here it is cervix. Okay, the cervix, anteriorly, posteriorly, and I will give the incision in the cervico-vaginal junction. You can see this. In the posteriorly, I am showing them that is lower border of the bladder. So lower border, we always try to feel at first the lower border of the bladder. So below the lower of the bladder, it is you can see, you can understand it is cystocele, na? Anterior vaginal wall swelling, the cystocele. So we should identify what is the lower limit of the bladder. And I am giving circular incision in the cervico-vaginal junction, why I will separate the vaginal wall from the cervix. And then I will open the posterior vaginal. I am separating the anterior vaginal wall from the cervix along with the bladder. You see the bladder, I am pushing the bladder. I am feeling the bladder, and this is the cervix, okay? The bolsellum lower part is the cervix, and this is the vaginal wall, and this is just behind the vaginal wall, that is bladder, okay? I think you understand? Okay. This is by the gauze piece, we do the dissection. So always we should be careful about the bladder. The bladder should be, from its position, it should be put in the upwards, so that there is no injury to the bladder. It is a very careful operation, and needs skill hand. I am opening the that is pouch of Douglas. You understand, the pouch of Douglas I am opening. And during this operation we should be careful about the injury to the rectum. Okay, I am separating from the laterally also, and then I will put the clamp, first clamp. I will put the in the first clamp. You know that by three successive clamp we remove the uterus from the body. Here in the first clamp, what would be the structure? Laterally the Mackender's ligament, and posteriorly uterosacral ligament. Understand? Okay, I will put the uterine. This is uterine. I am cutting just some portion, and I will put the uterine clamp now. I am telling them everywhere there is unskilled hand, so every time I should be careful. You see, I am showing this. It is the anteriorly Mackender's ligament, the whitish appearance, and posteriorly uterosacral ligament. So always hemostasis is important, and in the field but there should not be any blood, so that you can do operation easily. This is the uterine clamp. You understand the uterine clamp? এই মেয়ে তুমি পিছনে কথা বলতেছো কেন? দেখতেছো না কেন? কি দেখতেছো? বুঝতেছো? What is this? In the clamp, what are the structure? Macandros ligament and posteriorly intersectal ligament. Okay. So at first we clamping, three words: clamping, cutting, and ligation. Clamping, cutting, and ligation. So we do this, and then we do ligate, we do clamp, we do cut, and then we do ligation. Okay. After that, there is second clamp. Second clamp, what is the structure? Second clamp, uterine vessels. In the second clamp, uterine vessels. And what is the possibility of the injury in the second clamp? Ureter. Okay. Ureter is the possibility of the injury. If we push the bladder up, then there is no scope of the injury to the bladder. Okay. And we finish the second clamp here. So actually the video is not so. Uterus is so unusual. There is more elongated cervix. It is one of the complications of the uterine prolapse. There is more elongated cervix. You see, the cervix is more elongated up to this cervix. And then usually a cervix length how much? Only 3 centimeter. Here per double, more than double. It is one of the complications. It is actually, this case was associated with uterine fibroid. It is complicated case. So I dissect the uterus. Possibly I dissect the uterus, and then I bring in another way. This is, you see, it is what is this? This is visceral peritoneum of the bladder. This is peritoneum, pelvic peritoneum. I separate from the uterus. Just one vision about the hysterectomy. What is this now? What is this? Uterus, fundus. Okay. You see how long this uterus and cervix? More. And this is fundus, this is body of the uterus. So in the third clamp is the broad ligament, anteriorly round ligament, and ovarian ligament. This is the third clamp. If you do abdominal hysterectomy, then it would be the first clamp. Okay? Vaginal hysterectomy down, that is first clamp is the down, Macandros and intersectal, then transversal, then broad ligament, round ligament, and ovarian ligament. But if you proceed for abdominal hysterectomy, this will be the first clamp. Understand? Okay. Now you can show this, then I will remove, and then I will close. This is very bleeding. There is more possibility of the bleeding. So after operation, after closing all the vaginal wall, everything, we put the vaginal pack. You saw vaginal pack. We keep for vaginal pack at least 24 hours. And we keep catheter also for 3 days. You should remember this. After vaginal hysterectomy, always you ask 2 things. How many days vaginal pack and how many days catheter? Catheter 3 days and vaginal pack 24 hours. Why vaginal pack? As there is so many dissection of the vaginal wall, there is every possibility of the oozing. So to arrest the oozing and bleeding, we put the vaginal pack. What is this? Urinary Police catheter. We put in the police catheter. Where we are putting? Through the urethra in the bladder. Why we keep the catheter? Why we put the catheter? We want to raise the bladder. We want to raise the bladder. Why? As we so many handling in the bladder. So we push the bladder up. We form the bladder base, and we want to keep the position in the bladder. So if we give the rest the bladder by keeping the catheter for continuous urinary drainage, then there is more circulation and more healing, rapidly healing. So urinary catheter is kept to give rest to the bladder for rapid healing of the bladder base, okay, and other supports. Still going. And you see, this is the system. I do correction anterior colporrhaphy at the end of the after the removal of the uterus. I do the anterior colporrhaphy. You can saw this. I will do the anterior colporrhaphy. This is anterior vaginal wall. I will separate this from the bladder again, and I do easily to reduce the bleeding. You understand, this is anterior vaginal wall, okay? Behind this is the bladder. You should imagine, otherwise you cannot understand. And you already seen the video, so I think you can easily understand now. So anterior colporrhaphy for what you do? Anterior colporrhaphy for what? For correction of the cystocele. Very good. So I think the time is near end, and so you should follow the books. Better is Dept. I don't know you have Dept or not, and you should saw the picture, and you should imagine how it is happened, and you should take the history from the word. When you are in the block placement, you should be clear more. Okay? And any question from you? No? Okay, so today we can conclude the lecture. Thank you.